I'm Dr. Susanna Vanderpool. I'm a neonatal and pediatric clinical pharmacist, and in this video, we're going to be talking about neonatal early-onset sepsis. So sepsis is divided into early and late-onset sepsis according to postnatal age at onset of symptoms. Cutoff points have historically varied from 48 hours to 7 days, but the most common cutoff point today is 72 hours. And so neonatal early onset sepsis is sepsis occurring in a neonate within the first 72 hours of life. So organisms that cause early onset sepsis are colonizers of the maternal genitourinary tract. About a quarter of pregnant people are colonized with GBS or group B streptococcus. And so this is our number one organism causing early onset sepsis, making up over 40% of cases. Our second most common organism is E. coli, making up 30% of cases. However, in very low and extremely low birth weight neonates, this is actually the number one cause. Other organisms that we want to cover empirically but are not as common are Strep pneumoniae, Enterococcus, and Listeria. So the most common empiric regimen for early onset sepsis is ampicillin plus gentamicin. So this is our first line treatment option. So ampicillin covers group B streptococcus. E. coli resistance is actually pretty high today. About 50% of E. coli isolates will be ampicillin resistant, so unreliable for E. coli. But it also covers Strep pneumoniae very well, Enterococcus, and Listeria. So very good coverage for these gram-positive organisms. So gentamicin's role is mainly to cover this E. coli. Otherwise, it provides synergy for GBS, has a little bit of Strep pneumoniae coverage, but not super significant, no synergy here. And it also adds synergy for Enterococcus and Listeria species. So you can see with this regimen, we're covering all of these organisms very, very well. Also, GBS resistance to ampicillin and E. coli resistance to gentamicin has remained less than 10% over the last 10 years. So this is the most classic combination, and it continues to be the most common regimen today. So there are essentially only two scenarios in which you wouldn't use this empiric combination. The first is if you suspect meningitis. So ampicillin does penetrate the CNS at high doses, but gentamicin does not. And so with this combination of ampicillin and gentamicin, we're missing E. coli coverage in the CNS. And so that's where a cephalosporin can come into place. My preferred cephalosporin is cefepime. I have a video that goes over the different cephalosporins. And I also have a video on ceftriaxone's relative contraindication in neonates. So if you want to learn more about cephalosporins in neonatal sepsis and why cefepime is my preference, please check those out. So that's one scenario. The second scenario is AKI, acute kidney injury. Now, most neonates are not born with AKI, and immature neonates are really just at risk of AKI. So in that situation, if we're just at risk of AKI, I would still use gentamicin. And that's because gentamicin, compared to a cephalosporin, is a little bit safer. If you have true AKI, the risk of nephrotoxicity with gentamicin is significant, and so I would avoid gentamicin and use a cephalosporin in that situation. But otherwise, we can mitigate the nephrotoxicity associated with gentamicin by monitoring troughs closely. And the reason that we want to avoid cephalosporin overuse, in other words, not in these scenarios, right, is because cephalosporin use versus gentamicin increases risk of fungal infection, increases antibiotic resistance, and also puts us at higher risk of anemia and mortality. So next, let's talk about early onset sepsis duration of therapy. So there are essentially three scenarios that dictate the duration of our antibiotic treatment. The first one is culture-proven sepsis. So this means that the blood culture came back positive with an organism. We can narrow therapy and then treat for a duration dependent upon what organism. And so that will range between 7 and 14 days. And again, this depends on the organism that speciates. The second scenario is culture negative sepsis, meaning that the blood culture didn't come back positive, but we still have some conviction that the neonate might have sepsis. So the best chance of getting a blood culture to come back positive in a septic neonate is to obtain at least 1 ml of blood. Otherwise, the concentration of bacteria in the blood might be too low to grow out. And so in septic neonates, over 60% can have a falsely negative blood culture if only half an ml of blood is obtained. But the consequences of sepsis are so significant, right? And it's so hard to diagnose sepsis without a positive blood culture that we often do treat empirically for a full 7 days. Sometimes we can treat for 5 days, but for the most part, you'll see culture negative sepsis being treated for 7 days. We also call this presumed sepsis. Diagnosis is really challenging again because the signs and symptoms are very subtle and nonspecific. The lab values that we have that are best correlated with early onset sepsis and can help us diagnose culture negative sepsis are a white blood cell count less than 5,000, an I/T ratio greater than 20%, and an ANC or absolute neutrophil count value less than 1,000. So this I/T ratio is the one that you might be most familiar with. It's immature to total neutrophils, the immature neutrophils being at least 20% or more than the total neutrophil count. We can also utilize the Kaiser scoring tool in older infants to help us diagnose early onset sepsis, but this is limited to neonates 34 weeks gestational age and older. So for the younger infants, we still don't have much to go on for diagnosis. So again, treating for presumed sepsis for a full 7 days can be really important, as the consequences of sepsis are severe and include cerebral palsy and even death. So we have a low threshold for starting antibiotics. Then we'll reevaluate at 36 to 48 hours, because at that point, if a blood culture is going to be positive, more than 90% of them will be positive at this 36 to 48 hour mark. So at this point, if we no longer are suspicious for sepsis, then we can discontinue antibiotics confidently. And this is called a rule out sepsis. And the reason it's important to discontinue antibiotics if we no longer are suspicious for sepsis is because prolonged antibiotic exposure is also associated with adverse outcomes, which can include late onset sepsis, necrotizing enterocolitis, and again, death. And so we always have to balance between our conviction for sepsis and our conviction for not having clinically proven sepsis. So it's very difficult, but important because there's adverse outcomes on both ends. If we treat for more than 48 hours, so more than a rule out, with an antibiotic course that includes gentamicin, then therapeutic drug monitoring is indicated. And we should initiate therapeutic drug monitoring as soon as we think we might treat beyond 48 hours, because that will improve our chance of effective and safe use of gentamicin. Thank you so much for watching. Please let me know in the comments what topic you'd like me to cover next. And if you liked this video, please subscribe.